A very good morning, students. Okay, we will start part 8 of the pharmacology. We'll start the part 8 of the pharmacology class. I think previously we stopped at something near I think some of the drug doses. I think epinephrine drug dosages, the route of administration we reached. So actually previously I just want to say two important points I forgot to tell you. See, for narcoanalysis, the drug of the choice is thiopental sodium. Narcoanalysis, the drug of choice is thiopental sodium is the drug of choice. And if you ask me, truth serum in narcoanalysis is scopolamine. Scopolamine is just a truth serum in narcoanalysis. It is given as a transdermal patch 4 hours before the journey. So these 2 points, remember, the drug of choice for narcoanalysis is it's thiopental sodium, right? And the truth serum in narcoanalysis is scopolamine. Just remember, the truth serum in narcoanalysis is scopolamine, and the drug of choice for narcoanalysis is thiopental sodium, right? So that's okay. That's up to there. So welcome to the next topic, that is Dale's phenomenon. Dale's phenomenon is very important. You will get 2 MCQs or at least 1 MCQ from Dale's phenomenon. So you should be thorough with this concept, Dale's phenomenon, right? So what is Dale's phenomenon? We know that epinephrine is a drug which acts on alpha-1 receptor. Epinephrine is a drug which acts on alpha-1 receptor. So what happens is, in the heart, for the regulation of the blood pressure, actually we have we have multiple receptors, but in those we have alpha-1 and beta-2. But epinephrine acts on alpha-1 receptor. So when epinephrine acts on alpha-1 receptor, we just get a increase in BP, increase in blood pressure, and as soon as the drug concentration decreases, what happens? The beta-2 receptors comes into action. When the beta-2 receptors comes into action, it leads to decreasing of blood pressure. So this is called as this wave here. So you get a increase and a decrease in BP. This is called as Dale's biphasic pattern. So when epinephrine drug is administered, you get alpha-1 as a stimulation. It increases the blood pressure. After the decreasing of concentration of the epinephrine, the beta-2 receptors get stimulated. It leads to what happened? It leads to decreasing of blood pressure. So that is called as Dale's biphasic pattern. But if epinephrine is given with a beta blocker, what happened? If epinephrine is given with a beta blocker, as epinephrine acts on alpha-1 receptors, obviously the heart rate rises, or so-called the blood pressure rises. But due to beta blocking action of the drug, the beta-2 receptor action will not be there. So what happens? You will see only alpha-1 receptor action, that is only increase in blood pressure is seen. This is seen in epinephrine if given with beta blocker. This is called reversal of Dale. Just 1 minute. I'll come back. Just 1 minute. Okay, I think we are clear, we are audible, right? So this is called reversal of Dale. This is seen in epinephrine plus beta blocker, if epinephrine is given along with beta blocker. Now if epinephrine is given along with alpha blocker, can you tell me some of the examples of alpha blocker? Can anyone tell me some of the examples of alpha blocker? It's very much easy. What are the examples of alpha blocker? Prazosin, terazosin, toxazosin, tamsulosin. These are all alpha blockers, right? These all are alpha blockers. But what happens if epinephrine is given with alpha blocker? It's very much simple. As epinephrine acts on alpha-1 receptor, but due to giving of alpha blocker, giving or mixing of alpha blocker with epinephrine, the alpha-1 receptor is being blocked by the alpha blocker. So even though epinephrine is there, still there will not be any alpha-1 activation, alpha 1 receptor activation. So the BP obviously decreases, the blood pressure of the patient decreases. Instead of increase in blood pressure due to epinephrine, because as we have given an alpha blocking drug along with epinephrine, the alpha receptor gets blocked, by which the blood pressure gets decreases. Now this yellow color wave, this yellow color depletion in the blood pressure, this wave is called vasomotor reversal of Dale. So just remember one thing, Dale's biphasic pattern is seen when only epinephrine is given. Dale's biphasic pattern is seen when only epinephrine is given. Dale's vasomotor reversal of Dale is seen when epinephrine along with alpha blocker is given. What are the examples of alpha blocker? It's very much simple: prazosin, terazosin, doxazosin and tamsulosin. So when epinephrine is given along with alpha blocker, we see vasomotor reversal of Dale, right? When epinephrine is given with beta blocker, we see reversal of Dale, reversal of Dale, right? It's not reversal, it's reversal of Dale. Sorry, I should write it. It's reversal of Dale. You remember this very much important topic, Dale's phenomenon, right? I will tell you once again. Dale's biphasic pattern is seen when only epinephrine is given. Vasomotor reversal of Dale is seen. Vasomotor, see I am showing with the laser. Vasomotor reversal of Dale is seen when epinephrine is given along with alpha blocker. Reversal of Dale, this green color wave, reversal of Dale is seen when epinephrine is given along with beta blocker, because the beta blocking action, it just minimizes this depletion wave, right? You will have only increase in blood pressure, you don't have decrease in blood pressure. So that is called reversal of Dale. Yes, you remember this, that will be sufficient. Okay, now coming to the next topic, we were here with drugs for glaucoma. So what are the drugs for glaucoma? These things are very much important. Drugs for glaucoma is a important topic, so kindly remember. What are the drugs for glaucoma? So we will start with something called prostaglandin analog. What are the important drugs in prostaglandin analog? It is latanoprost and bimatoprost, right? These two are important. What they does is they increase the uveoscleral outflow. They increase the uveoscleral outflow. And remember one more thing, these are the drug of choice in open angle glaucoma. Prostaglandins are the drug of choice in open angle glaucoma. And remember, they increase the uveoscleral outflow. That is the mechanism of action. Remember, it's very much important, right? If there is no response with the latanoprost, if there is no response with the prostaglandin, then you just add beta blocker. If there is no response with the prostaglandin analogs, you just add beta blocker. Now if you ask me some of the side effects of these drugs, it is very much simple. First one is iris pigmentation. We see something called iris pigmentation. This is an important MCQ. You will get a image. Iris pigmentation, also called heterochromasia iridis. So you see iris pigmentation, also called heterochromasia iridis. Then there is also trichomegaly, enlargement of eyelashes. There is also trichomegaly, growing of eyelashes. Then there is dry or sandy eyes, and it also causes cystoid macular edema. Prostaglandin analogs cause cystoid macular edema. This is very important MCQ. Cystoid macular edema. Then they are highly contraindicated in, remember guys, remember this thing, it is a INCT question. They are highly contraindicated in keratitis. Which keratitis? Herpetic keratitis. Herpetic keratitis. They are contraindicated in keratitis. Remember this, herpetic keratitis. Why? Because, can anyone tell me? Because what happened? Because they increase inflammation. Because prostaglandins, why? What is the action of prostaglandins? Prostaglandins simply increase the inflammation. Wherever they are, they increase the inflammation. Okay. Then what are the next sort of drugs? Beta blockers. What are the next drugs? Beta blockers. Now, what are the beta blockers that are given in glaucoma? Can anyone tell? First one is timolol. Next one is metipranolol, livobonolol, cartiolol, betoxolol. But remember, two drugs from all these drugs, that is timolol and betoxolol. These are very important anti-glaucoma drugs, and these are second line of drugs in open angle glaucoma. What are the first line or drug of choice? That is prostaglandin lanolin, latanoprost and bimatoprost. Now, what are the second line? That is beta blockers. Now, what are the complications, side effects? These are very important. Side effects are, timolol causes very important, very dangerous side effect called nasolacrimal duct obstruction. Nasolacrimal duct obstruction. Okay, due to stenosis. Why? What happens due to stenosis? Due to stenosis, there is NLD obstruction. There is nasolacrimal duct obstruction. Metipranolol causes granulomatous anterior uveitis. Metipranolol causes granulomatous anterior uveitis. Remember this very much. And remember one more thing. What is the contraindication? Systemic beta blockers. Right? Systemic beta blockers should not be given. They are highly contraindicated. Okay, highly contraindicated. Now, what are the other drugs? Other drugs which are given are epinephrine and dipivefrin. Remember these two drugs, it is very much important. Epinephrine and dipivefrin. Dipivefrin. Epinephrine and dipivefrin. See, remember these two drugs. What is important in these two drugs? Very important thing is the side effect. The side effect. They cause black pigmentation of conjunctiva. They cause black pigmentation of the conjunctiva. What are the two conjunctivas that are present in the eye? Palpebral conjunctiva and bulbar conjunctiva. So, what happens? Epinephrine and dipivefrin, what is the side effect? They cause black pigmentation of the conjunctiva. Why? Can anyone tell me? Because epinephrine metabolism leads to formation of melanin. This is the reason behind this black pigmentation. The black pigmentation is formed due to epinephrine being metabolized to melanin. Okay, up to there we've done this. Next, I just want to know, anyone want the glaucoma? Anyone wants any class or any information or any topic about glaucoma? You please comment down in the comment section. Please, I am very much happy to look forward through it. Right? Okay. Now the next drugs are alpha 2 agonists. Alpha 2 agonists. What are the alpha 2 agonists? Apraclonidine and brimonidine. Guys, remember this brimonidine. It is mostly used for glaucoma in practical purposes. Right? Now, it's okay, they are used for glaucoma, but still the side effects of apraclonidine are very much important. What are the side effects? It causes lid retraction. It also causes mydriasis. It also causes conjunctival blanching. Apraclonidine causes conjunctival blanching. Remember this, very important. Next, brimonidine, it can cause blood-brain barrier, so which leads to very important dangerous side effect. It causes central sympatholytic action. sympatholytic action. So it causes apnea in children, it causes apnea in neonates, not even children, it causes apnea in neonates. And also it causes drowsiness, somnolence means, and anyone, what is somnolence? Excess sleep. What is somnambulism? Sleepwalking. What is insomnia? Sleeplessness. Remember these terms are very important: somnolence, somnambulism and insomnia. Somnolence means excessive sleeping. Then these brimonidine also cause hypotension. Okay, now that's okay, that's up to there. Now what are the next drugs we see? These are meiotic agents. Can you tell me which drugs cause active meiosis? Can anyone? Those are cholinergic drugs. Cholinergic drugs means acetylcholine, pilocarpine, then anticholinesterases or cholinesterase inhibitors. These are meiotic agents. What are mydriatic agents? Passive mydriasis is caused due to who? Anticholinergics. Active mydriasis is caused due to adrenergics or sympathomimetic drugs. Next, sympathomimetic drugs. Now when we come to meiotic agents, what are the meiotic agents that are used in glaucoma? Can anyone tell? It is pilocarpine, the first one. Remember this drug, it's very important, and its mechanism of action is also very important. Please read this twice. Pilocarpine, physostigmine, ecothiophyte, carbachol. We use all these drugs as meiotic agents in glaucoma, but what they do is important. They increase the trabecular flow. Guys, remember all the mechanism of actions of all glaucoma drugs. This is the potential MCQ. So pilocarpine is the drug of choice in closed angle glaucoma. This is very, very important MCQ. Now pilocarpine can also be used as third line in open angle glaucoma. Now the side effects of pilocarpine is very important. You can simply remember with a mnemonic called pilo at bar. You remember this mnemonic. Now what is the mnemonic expansion? P for anyone? Pilo at bar. Can anyone tell me? Can anyone? B for Browick. A for accommodation spasm, and R for retinal detachment. Guys, remember this, very important. Detachment. R for retinal detachment, B for Browick, A for accommodation spasm, and R for retinal detachment. Now ecothiophyte, one more meiotic agent we already spoke. Ecothiophyte causes iris cysts. This is also very important. Iris cysts, very important. Now ecothiophyte or physostigmine, they can cause cataract. Ecothiophyte or physostigmine, they both can cause cataract. So these are, remember, pilocarpine causes bar, Browick, accommodation spasm and retinal detachment. Alright. Now we come to the next drugs. What are other meiotic agents? Oral or IV acetazolamide. What is acetazolamide? Can anyone tell me? Acetazolamide is a carbonic anhydrase inhibitors. inhibitors. Remember this. Now, how does acetazolamide is used? Acetazolamide is mostly important in acute congestive glaucoma. Acetazolamide is very useful in acute congestive glaucoma. What it does? It increases the trabecular flow. It increases the trabecular flow. Okay. Now, what are the topical drugs? If you ask me, what are the topical drugs? Topical drugs is brinzolamide. Brinzolamide. It is also a carbonic anhydrase inhibitors. Brinzolamide and dorzolamide. Dorzolamide. It's also a carbonic anhydrase inhibitors. Brinzolamide or dorzolamide, they are used in open angle glaucoma. They are used in open angle glaucoma, but they are third line drugs. Open angle glaucoma, I just want to say one thing. What are the first line drugs? Prostaglandin analogs. What are the second line drugs? It is beta blockers. And what are the third line drugs? They are carbonic anhydrase inhibitors. As well as meiotic agents also. What are the meiotic agents? They are cholinergics. What are the carbonic anhydrase inhibitors? Acetazolamide, brinzolamide, dorzolamide. Right? That's it. What are the complications of pilocarpine? Side effects of pilocarpine: brow ache, accommodational spasm, and retinal detachment. These are very important. Now you come to one more drugs which increases the trabecular flow, that is natarsodil. One more drug which increases the trabecular flow, that is natarsodil. It increases the trabecular flow. That's very important. And it is also a third line drug in open angle glaucoma. It's a third line drug in open angle glaucoma. But the most important thing is natarsodil causes a side effect called cornea verticillata. We have multiple drugs which cause cornea verticillata. It is something like horror like cornea. Okay, horror like cornea verticillata, which is the side effect or complication of natarsodil. Remember, it's very important. Sure shot MCQ. Now remember one statement: you should never give 2 beta blockers. Even though they are topically administered. You should not give 2 beta blockers at a time. Why? Because it may lead to decrease of AV or atrioventricular conduction. This is the reason you should not give 2 beta blockers at a time in case of glaucoma. Why? Because it may decrease the AV conduction. Okay, that's it. That's up to glaucoma. Now we will come to antiarrhythmic drugs. Very important. Antiarrhythmic drugs, you will get one ECG which is mixed with a pharmacological question. You will get probably ECG plus pharma orientation question in case of arrhythmic drugs. So what are the, so you have atrial arrhythmias that are arising from atria, and you have arrhythmias that are arising from the ventricles. Now we will discuss about arrhythmias arising from the atria. What are those? Supraventricular tachycardia, paroxysmal supraventricular tachycardia, now atrial fibrillation, atrial flutter. Atrial fibrillation will keep FI, and atrial flutter AFL, atrial flutter. What is the treatment of supraventricular tachycardia or PSVT? Simple is adenosine. See, I just want to tell a mnemonic, you just remember through that mnemonic. Okay, I just want to tell you that mnemonic, that is A, B, C, D. So simply remember A for adenosine, B for beta blocker, C for calcium channel blockers, and D for, can anyone tell what is D for? It's D for digoxin. Now can you tell me what is the Antidote for digoxin toxicity, it's digibind. Remember, always masticate the things which you read. Always try to masticate it as many number of times, because it will become a permanent memory. So what is the treatment of SVT, supraventricular tachycardia, and paroxysmal supraventricular tachycardia? It's ABCD. What is meant by ABCD? It's adenosine, beta blocker, calcium channel blocker, and digoxin. The antidote for digoxin poisoning is it's digibind. Now adenosine is given IV, beta blocker you can give IV or oral, calcium channel blocker also can be given IV or oral, and digoxin is given oral, right? Now you will get one more question. What are the two main drugs used CCBs in case of SVT or PSVT? The two main drugs which CCBs are given are, that is verapamil and diltiazem. Okay. Now if I ask you, or if you ask me, what are the complications, sir? What are the complications of these four drugs, right? In these four drugs, if you take the first alphabet A, which belongs to adenosine, A for adenosine, it is highly contraindicated in COPD and asthma and atrial fibrillation. Remember, adenosine is contraindicated in COPD, asthma, atrial fibrillation. Okay. Now if you come to the beta blockers, B for beta blockers. Beta blockers, what are the side effects? Beta blocker side effects are very simple. Previously I think we heard, right? Beta blockers, they are contraindicated in COPD and asthma. Can anyone tell me why? Why beta blockers are contraindicated in COPD or asthma? Simple. What they do? Beta blockers, what they do? They cause bronchoconstriction. Beta blockers cause bronchoconstriction. So that's why we used SABA, LABA, long acting beta agonist, short acting beta agonist. What are short acting beta agonists? Can anyone tell? Salbutamol, terbutaline. What are the long acting beta agonists? It's salmeterol, formoterol. What are the very long acting beta agonists? It's pirbutrol, olenterol, viditrol. These all are very long acting beta agonists, right? So I think we done the so called arrhythmias also. Now we will just check some important points here. What you will do if a patient get an acute attack of arrhythmia, right? First one, it always prefer IV drugs. In IV drugs, what is the king? It is IV adenosine followed by beta blockers followed by CCB. So remember this. So if you get a patient to the OPD with an acute attack of arrhythmia, so be it something like PSVT or SVT. So what you will do, the first thing is always give IV drugs. The time, for example, if you give oral drugs, in the meanwhile the patient may collapse, land up in coma, and finally be dead, right? So it's always be safe to give the IV drugs. What are those IV drugs? That is, first one adenosine followed by beta blockers and followed by calcium channel blockers. Now if you ask me what is the treatment for maintenance, continuous phase, it's not loading phase. If you ask me what is the treatment for maintenance phase, then obviously it should be digoxin more than or more prior than CCBs. Calcium channel blockers more superior than digoxin. So if you want to give a long term oral therapy to the patient, then always you give CCBs, oral CCB greater than digoxin. Okay, this is the protocol. Okay, now I think up to here it's okay. Now when you come to atrial fibrillation or atrial flutter, if you want to talk about these three things, what are the treatment of atrial fibrillation or atrial flutter? If you get an acute attack patient, so it is cardioversion. Remember, cardioversion plus or minus, that is with or without ebutilide. So when you get a patient with acute attack of atrial fibrillation or atrial flutter, you will do cardioversion with or without ebutilide. But if you ask me what is the long term treatment, then I always suggest you to follow a protocol. What is that? If you want to just give long term treatment, then obviously your first and wise option is to keep the ventricular rate less than 100 beats per minute. This is very, very, very important. Even most of the postgraduate doctors fail to answer this. What is the first step you do in a protocol for long term treatment of atrial fibrillation or atrial flutter? So the first thing is we have to keep the ventricular rate. You should control the ventricular rate. So it's called ventricular rate control, to keep the ventricle rate less than 100 beats per minute. You just do the ventricle rate control and you keep it less than 100 beats per minute, right? Just one thing.